This is my disclosure, and this is the agenda for my presentation. Just a few words about background, then we'll see what works for PrEP, what we know that works. Then we'll see whether we could have better options for PrEP, and then we'll go straight to the potential role of integrase inhibitors for PrEP. And at the end, I hope that there will be some discussion. So before start, just let me show you this data, epidemiological data. This the incidence rate in Europe, and as you can see, there has been an increase, a dramatic increase of the HIV incidence among MSM in these last years. It's an increase of 44%. The good news, it seems that in some cities, London, San Francisco, that this incidence rate is going down now. I'm sure that because of the treatment as prevention, extension, and also for the PrEP, I think that PrEP is starting to produce the results. No? But anyway, I think that this shows that in prevention, probably we are not doing all we could do, or we are not doing the best in prevention. We know that the prevention based on ARVs has become a cornerstone of HIV prevention, either through the treatment as prevention or post-exposure prophylaxis, and mainly for the pre-exposure prophylaxis, in which I'm going to focus on. So we know, just to review what we know works for PrEP. There are several clinical trials where it has been shown the efficacy of oral drugs, antiretroviral drugs for PrEP. I'm going to focus on the oral PrEP, and in different population groups. And among MSM and transgender women, there are three important clinical trials: the IPREX, the PROUD, and the HyperGay, where the efficacy was shown, and in the PROUD and HyperGay, the efficacy was up to 86% on reduction of HIV incidence with the Truvada, oral Truvada, and also has been shown in heterosexual men and women. Regarding women, there are two clinical trials where there was no protection or reduction of the incidence. This was the FemPrEP and the VOICE clinical trials. And this was due to the adherence, that there were the adherence was bad in both studies, and that's why it didn't work. And also in people who inject drugs, also it has been shown the efficacy of the Truvada in this case for the PrEP. As you can see, the adherence is strongly related to the efficacy of the PrEP. As I said before, the FemPrEP and the VOICE with low adherence rates, and there was no protection or efficacy. Also, we know that the toxicity of PrEP is not a big issue, although, of course, there can be toxicity, mainly what is called the startup syndrome, which is the nausea, vomiting, usually for the first weeks of the treatment with Truvada. And also we know that the bone can be affected. We know that there can be a decrease of the bone mineral density of around 1%. Also, we know that the Truvada can affect the kidney, and when we do PrEP with Truvada, we have to monitor for that. But as I said, the toxicity is not a big issue for the PrEP. And what about in real world? Well, we know that also PrEP works. This is one of the first studies which was published, and it's a study implemented in San Francisco among more than 650 MSM. And during a follow-up of up to 32 months, no new infections detected. There are more now. There are different implementation studies ongoing in Belgium and also in Holland and other places, and we know that the results are even better than in the clinical trials. Always, well. Not always in medicine, 100%. It's difficult to get, but we know, for instance, that there has been 2 cases of transmission by multi-resistant virus, one in Canada and the States, and also in the UnPrEP study, which is the demonstration project implemented in Amsterdam, with more than 400 participants, they have observed one case, one seroconversion, and they don't explain. I was talking with them, and they don't know why this seroconversion occurred, because he was adherent, and maybe, well, maybe it could be a clue that he is a man with a very active sexual life. On average, he had more than 3 partners, sex partners a day, which is not too bad. And so I don't know whether this could explain that, but it's a fact. And then the next question is, can we have better option for PrEP? We know that this with Truvada, most of these studies have been implemented with Truvada, or some with only tenofovir, and we know the efficacy. But can we improve? Can we have better options? Well, I think yes. This is which options? This is the Discover study. It's an ongoing study to show the efficacy of the TAF along the emtricitabine for PrEP, and it's a phase 3. It's a double-blind clinical trial, and they compare. The objective is to compare the Truvada with the TRAF. No? It's a quite large study. It's the population study. The sample size is 5,000 MSM and transgender women. The inclusion criteria is high risk for HIV infection, as you can see. They have multiple partners, sex partners, and they don't use condom, at least not systematically. And this study just has started last September in the States, later in Europe in January, so no results so far. If the efficacy of TAF plus FTC for PrEP is shown, well, the advantage would be the less toxicity, especially for kidney and bone, but the startup syndrome could be the same, and we don't know whether it also would work for the on-demand or event-driven regime, which is the one was shown in the Hypergay study. It means that you don't have to take the pill on a daily basis, but you take the pill before you have sex. And with this study, we couldn't show that. And also the cost. This is an issue that could be a barrier for the use of TAF, because if we have generic Truvada available in a few years, I guess that many health systems couldn't afford to pay for the TAF, which is going to be more expensive, but they would they also could afford for the generic Truvada. But I don't know, just this is more a matter of policy than research. But anyway, it's something which should be taken into account. Other options, the Maraviroc, and could be a better option in terms of less toxicity. There is a study, the HPTN 069, has been implemented among MSM and also in women. In MSM, there were 5 seroconversions, 4 were associated with undetectable or low levels of Maraviroc, but another one, no. And among women, there were no seroconversions. My team, I myself, implemented a study with 10 volunteers, healthy volunteers. We took rectal biopsies, and we had given them a single dose of Maraviroc, 8 we gave Maraviroc and 2 Truvada, and then we exposed the tissue samples to the HIV, and all of the samples with Maraviroc became infected, but not any of the Truvada group. This is a personal opinion, but I wouldn't feel so happy or so sure with Maraviroc for PrEP, but so I don't think this is going to be an option, but well, or maybe I'm wrong. And another possible use for PrEP of another drug is the rilpivirine. This study is the HPTN 76. It's a study with, they compared the design is with rilpivirine, but a long-acting formulation. This study is with placebo. It's implemented among women at low risk of HIV infection, and after an oral phase for 4 weeks, they go into the injection phase, and they deliver the rilpivirine long-acting every 8 weeks. It's an ongoing follow-up. So now we'll see the results. And just now let's go straight to the integrase inhibitors for PrEP. Well, so far we have the raltegravir, elvitegravir, and dolutegravir. I don't think this Gooden adds very big advantages, and even raltegravir could be, until we have the once-a-day formulation, if it has to be taken twice a day, this could be a barrier for many people, probably. Elvitegravir it goes along with other drugs, so not for PrEP. And dolutegravir, well, could be, yes, but we would need studies for that. But the next one which is the cabotegravir, the long-acting injectable cabotegravir, could be really a good option, a good alternative for PrEP for many people. So I'm going to review the studies which are being implemented with the long-acting cabotegravir. First one is the HPTN-077. This is with almost 200 men and women, also at low risk for HIV infection, and they use placebo. I want to stress to highlight that these kind of studies with placebo probably, well, right now, probably no, I'm sure that right now couldn't be designed, couldn't be accepted because of ethical reasons. We cannot compare placebo with for PrEP, because we know that there are agents, drugs, which already work for that. But this design was, I don't know when was done, but anyway, it's population, low-risk population, but anyway, for me, I wouldn't feel very happy also with this kind of designs. And the same, an oral phase, always when we use long-acting injectables, we have to do an oral phase first, usually 4 weeks, to be sure that there are no adverse events, which could be really difficult to manage if we start using the long-acting formulations. Because as you have seen in some different sessions this morning, these drug levels of drug can persist for months. So this study will see the results in this conference, in the ACE conference, and I don't remember, I think it's Tuesday, not sure. And I'm going to focus and to spend more time on the ECLAIR study, which is a phase 2 study to evaluate. It's sponsored by VIV, and the primary objective is to evaluate the safety and tolerability of cabotegravir long-acting injectable, and the study population is men at low risk for HIV infection, defined by at least 1 casual sex partners in the past 24 months and no more than 3 within 3 months of screening, so really low risk. The design is this: so after the oral phase for 4 weeks, they receive cabotegravir oral or placebo, still with placebo. After that, in the injection phase, they are administered the injection, cabotegravir or placebo injectable, every 12 weeks. Some results. Well, they observed that the cabotegravir concentrations were lower than expected. In this graph, you can see the green line, that at some points the concentration, the drug levels, was below the expected 4 times the protein adjusted CI90. EC90. And they think, or the investigators think, that this is because the period, the 12 weeks could be too long for the interval. But well, this was the results. And they observed 2 seroconversions. One was in the placebo arm, and another one was in the cabotegravir arm. But was 24 weeks after the last injection. So probably the levels, the drug levels were very, very low or undetectable. In terms of tolerability and acceptability of the cabotegravir injections, in this table, you will see that there was a difference between the placebo and the cabotegravir group. And in the cabotegravir group, there were more adverse events. And the main adverse event was the injection site reaction, mainly pain. You see that in 92% of the cabotegravir group felt pain in the injection site. Also, other symptoms like pruritus or swelling or some bump also was registered. And when they were asked whether they have felt some pain or discomfort and how satisfied they were with these symptoms, in the placebo group, most of them said they no symptoms or just a few, no pain or just very little pain. Whereas in the cabotegravir group, you can see that only 12% said that they hadn't had any pain. It's surprised a little bit because when they were asked about the satisfaction with the side effects, the placebo group said 100% satisfied. But in the cabotegravir group, in spite of having had pain, most of them, 66% said they felt satisfied with the study medication, and they wouldn't change. This is in this slide you can see when they were asked whether they would change the medication or they feel how happy they feel or how satisfied they felt with the current medication, which is the injectable. Most of them were satisfied and saying, yeah, and I wouldn't like to continue with the injections. More in the placebo group, but also in the cabotegravir group, as you can see, in the week 6, along the week 6, 18, and 13. Which means that pain, but not affects or not at a high degree affecting the satisfaction of the participants in the study. There is a sub-study within the ECLAIR study, which I think is interesting, and it's a qualitative study. They interview 26 participants of the study and 4 healthcare providers, and the results are the same. They say that almost all participants experience some pain. But even that, in spite of that, they were satisfied and interested in continuing with the treatment, with the injections. The participants described the treatment as being very convenient because they described the advantage of not having to be worried about missing a dose, so don't have to think about the daily dose. They felt much more comfortable. And some participants, especially from San Francisco, said that they are surrounded by a culture where an MSM is expected to be on PrEP, to be seen as a safe sexual partner. Some years ago was the opposite. People taking PrEP was seen as a risky person. Even some people were talking about the Truvada horse, but now it's changing rapidly, this perception of the people taking Truvada for PrEP. No? And the providers expressed the need for guidelines to assist patients in choosing the best PrEP regime. Some sentences taken from this study is the first one. One of the participants said, yeah, definitely I would recommend the PrEP because you don't have to remember to take the pill every day. So yeah, I'm very in favor of taking receiving the injection. No? And another one said, yeah, I'm thinking that the injectable is also very useful because you don't need to plan in advance whether you are going to have sex, or you can feel much more comfortable, and you don't need to be so to have the agenda for your sex. No? I would like, if I have time, I would like to do just a quick survey among you. I would like to to ask you, if you were on PrEP, would you prefer to take a pill every day, or you would prefer an injection every 2 months? Please raise your hands who would prefer a pill every day, a daily pill. Okay. And who would prefer an injection every 2 months? Oh. Wow. Have you seen? It's interesting because I see that most of you prefer spontaneity and you don't like planning when talking about this. Interesting. No, just kidding. Another study, the last study I'm going to talk about, it's also on cabotegravir, is the APTN-083. And in this case, it's not placebo anymore used, but Truvada. I compared the cabotegravir, long-acting cabotegravir, with the Truvada. And it's also a large study, 4,500 people. The inclusion criteria is also, they are MSM and transgender women also at risk for HIV infection, and they are recruiting participants, so no results so far. The design is, as usual, the oral phase for 4 weeks, and then an injection, the cabotegravir injection or cabotegravir placebo, or the Truvada placebo, and every 8 weeks. So let's to summarize the advantages of disadvantages of this new formulation, the cabotegravir, and let's start with the disadvantages or possible potential disadvantage. I see that what we mentioned before, if there is no oral phase, then it would be really difficult to manage with adverse events once the long-acting injectable it's been delivered, it's been administered. Regarding adverse events, most of them will have pain in the injection site reactions, and in fact, 4 of the participants of the ECLAIR study left the study because they said that it was not a big issue, was not a serious adverse event, of course, but they didn't want to continue because they didn't tolerate very well the pain. No? But there were only 4. No? But yeah, of course, this adverse event has to be very taken into account. No? And an issue which could be a problem is the risk for development of resistance, especially during the tail, the pharmacokinetic period, because it's, as we have seen, the tail, it's a long tail, and with low levels of drug, of cabotegravir in this case, and in this case could easily develop a resistance. Huh? So it would be, if we use cabotegravir, long-acting cabotegravir, adherence should be very, the participant or the person who take that should be advised and should be stressed that after the 2 months or the period of time, then the injection should be repeated or an oral PrEP, but it should be covered with drugs. Otherwise, he would be on risk. Something which could be a barrier is, from my point of view, is if the cabotegravir injectable can be only delivered at hospitals, then many people wouldn't feel very happy, because remember that we are dealing with people, healthy people, not patients, not people with HIV. Sometimes they are very reluctant to go to the hospital. And in fact, I'm going to show you data from the Flash PrEP survey. This was implemented last year in Europe. The results are going to be presented also in this conference. And it's an online survey with almost 16,000 participants, mainly MSM, in 12 European countries. And when they were asked where they prefer to, how and where they prefer to receive the PrEP, they said, well, within that, 85% said PrEP should be a comprehensive package with STI screening and treatment, of course, and should be delivered first in a community health-based center and second by the GP. But not the hospital was the last place where they would prefer to receive the PrEP. Let's go to the advantages of this formulation, this kind of PrEP. Well, we would expect better adherence with the long-acting injectables, of course. And I think there is no doubt on that. Satisfaction is high in spite of this side injection reaction, but we've seen that they feel quite satisfied. And preferences, the qualitative study show how they would be preferred by many potential users, and because this peace of mind, to feel comfortable and don't worry about to have to take the pill every day. Of course, the reduced toxicity because of the integrase inhibitors by itself, but also because the lower dose with this long-acting formulation, we would need a lower dose, and also because we avoid the first-pass metabolism, which would also facilitate the lesser toxicity. And another point which is interesting from my point of view is that the use of this of the cabotegravir long-acting would contribute to reduce the risk of transmission, because if we improve the adherence, I'm talking about a person with HIV on treatment with this long-acting, if they are undetectable, we improve the adherence of people with HIV, then we also decrease the risk of transmission, as the concept of transmission, treatment of transmission. As conclusions, I would say that the daily oral PrEP has proven effective in clinical trials and also in implementation studies in MSM, discordant couples, and people who inject drugs, but less so in other populations. The efficacy is strongly related to the adherence, as we know. That the long-acting injections may overcome barriers to adherence. That seems clear. This kind of formulation could be preferred by many potential users, as we have seen. And the cabotegravir is a potent integrase inhibitor that has been formulated in the long-acting nanosuspension. And I think that the long-acting cabotegravir is a promising option for PrEP. And that's all. Thank you very much.